Now, doctor, you've had a patient, they've been diagnosed with FAI. What is the type of treatments they're looking at?
All right. So, as everything, you start simply. Okay. If it's a mild case and it's only brought about by certain severe activity modification, always start conservative. The next thing would be physical therapy, physiotherapy. You try and improve their range of motion, muscle strengthening, things like that. There are also alternative methods such as I know a lot of my patients, some of them go for acupuncture, traditional medicine, and you know what, if it helps with your pain, I'm all for it. Now that's the conservative side out of the way. Now if you are still having symptoms, you could treat it medically. Okay, we try and get rid of your pain, and this is by painkillers. If painkillers don't work, or if I'm looking for a more diagnostic thing, I sometimes inject local anesthetic into the joint. Okay, this targets, and not only is it diagnostic, it's also therapeutic. And once I have done this, and this is the medical side of things done, then you look at surgery. So surgery is that's where we come in. So historically, surgery for FAI has always been open surgery. It's massive surgery. It's actually, you'll have to open up the hip joint. The hip joint it's a big joint. Yeah. You open it up, you need to do osteotomy, that's cutting bone, and just to expose the hip, and then you clean it out. We call it a surgical hip dislocation. That's the traditional thing. Now, however, with technology, I think it's moving closer more and more towards hip arthroscopy. Okay. This is very, very good. I myself I'm a fellowship trained surgeon in hip arthroscopy, where from these big operations, opening up the hip, you do it via tiny incisions, maybe 2 or 3, less than a centimeter. You insert a camera lens and insert a pot with arthroscopic instrumentation, and you can address the bony spurs that account for the patient's symptoms. And that would be, at the moment, that's definitely being the mainstay, especially in dealing with mild to moderate FAI. Of course, in some cases you just can't help it. It's severe FAI, there's just too much of bone, and in that situation probably we still go for surgical hip dislocation.
Okay, let's talk about the current conversation on the conservative part versus the surgery part. As a patient, you said that now you have FAI. As a patient, how can I make that decision whether I would want a conservative approach or a surgical approach?
If you have, if you are a patient that is, your symptoms are mild, to me, I would almost always start somebody on conservative management. Don't throw the surgical knife on everything. So definitely give a trial. You can try it for a couple of weeks, see how it goes. If it settles the problem for the patient, by all means, you save the patient an operation. However, there are times where I can see where there is actual problems within the hip joint. A classic example is labral tears. Now labral tears don't heal on itself. Now if there is a labral tear there, I am more I would lean more towards a more aggressive approach, hence surgery. Because even though you conservatively manage these patients, the tear is not going to heal with the synovial fluid going in between, and in the end may lead to a higher risk of degeneration and therefore lead to arthritis. So in those situations, yes, I would lean towards surgery. Surgery, as a general rule, should be attempted after failure of conservative management. But there are also always some, areas where you actually, prefer surgery earlier, and an example would be in a condition where there's labral tears.
Okay, all right. Now, how safe is the surgical procedure? You talked about surgery. How safe is it, and what is the recovery period that the patient has to go through?
So, if you're looking at hip arthroscopy, compared to traditional open surgical, definitely it is safer. Again, it's much smaller, minimally invasive. In a lot of centers around the world, it's done as a day case. You come in the morning, you go and have in the afternoon. So the recovery for the patient again depends on what is done. If you, like a normal FAI case, where there's a pincer and a cam lesion, you will require debridement and labral repair. So in those situations, I would normally keep the patient either overnight or the same day, depending on how his pain is okay. I would keep him on crutches for protected weight bearing for maybe a couple of weeks, and we see how he goes. He goes through a period of physiotherapy, which is very important to strengthen his muscles around the hip, help him recover faster, help him to get on his legs and get moving faster, and it's just beneficial in the long run. Okay, so these are the things, and normally the patient would be on protected weight bearing for anywhere between 4 and 6 weeks.
Okay.
And if you work you're a desk job, you could go back to work within 2 weeks after the operation, maybe on crutches, but it'll be up to 2 weeks. If you are an athlete, say you played football for Malaysia, you may be out of action for about 3 months, but you'll be back in the gym, I would envisage around the 6-8 week mark.
Okay.
And you're talking about safety, so any operation, there's complications, you can't run away, but as I said, because it's minimally invasive, the risks like infections, nerve damage, wound problems, and even the risk of revision, it is slightly lower when you do arthroscopic surgery.
Okay.
So there is a good paper out there looking at readmission from hip scopes. I believe it's Dishen's paper. This is about 2 years ago, and their readmission rate for complication is 0.2%. Which is very low. But however, this readmission, so you'd expect higher complication, but in my experience looking at the literature, definitely less than 4 or 5%.
Okay. And talking about the success rate, what do the patients really, is it more about finding the problem early? And how does that affect the success rate?
Yeah, talking about success rates of, let's look at hip arthroscopy done for femoroacetabular impingement. Success rate, this is in the literature, it's around 85% roughly. I think it's around 85 to 86% return of competitive sports in an athlete. It's a really good 85%. Yeah. In the normal population, anywhere between 80 and 85%. Okay, again, still very, very good. This is return to pre-injury or pre-symptom level. When it comes to when it comes to success rates for the patient, of course, this is the importance of counseling. So somebody, if he's seen early, identified early, it stands to reason that his success rate ought to be better than someone who's diagnosed late or missed. Okay. And we also know that patients who are advanced in age, say you're doing a hip scope in somebody who's 40, 50, patients who already have signs of arthritis when you're doing your hip scope, those patients tend not to do so well. They end up with joint replacement much more than you would expect somebody who's younger, who was attempted earlier.
And so it's all about finding the problem early.
Yeah, yes. If you could find the problem early, it's going to definitely be better for the patient, in my opinion, anyway. So.
Okay.